Hello, my name is Jasmine Smith, and I will be going through my template on how to conduct a low back examination. So, first, we have the history. This is where we want to talk about the mechanism of injury. Is it acute or is it insidious? We want to know how long this has been going on. So, less than 4 weeks, 4 to 8 weeks, more than 8 weeks. We want to know if the patient has had any previous injuries, as well as what position the patient sleeps in. So, are they on their side, their stomach, or on their back? We want to know if there is anything that makes the pain better or worse. So, are there any positions the patient is avoiding, or if there is any positions the patient tends to go to because the pain is less severe? We want to know what the daily activities of the patient is, and has there been a recent increase in activity, as well as what does the patient do for work. So, are they carrying heavy loads? Are they on their feet all day? Questions like that. We also want to note if there has been any bladder, a change in the bladder or bowel movements, as well as any recent weight loss, because that is a red flag for something else is going on besides the back pain, as well as the current medications the patient is on and the overall general health of the patient. So, is the patient fairly healthy? Does the patient have any health conditions or anything like that? What is the overall health status of the patient? So, next we have pain. We want the patient to fill out this graph or figure to see where the patient experiences their pain. So, is it only on the back, or do they feel it in their legs? We also want to know what is their pain like. So, is it on a scale of 0 to 10, 0 being nothing at all, 10 being the worst? What is their pain? What is their current pain? We want to know what is their worst pain and what is their best pain. We also want to know what the pain type is. It dull? Is it sharp? Is it tingling? Do they feel numbness? And then, as well as, is it constant or is it intermittent? We want to know, again, what activities they do that causes this pain. So we want to know a little bit more specifically what is it that they're doing that causes that pain. We also want to know, when is the pain worse? So is it worse in the morning, evening, afternoon, or nighttime? And if they are experiencing night pain, we also want to note that, because that is another red flag that something else could be going on. We also want to know what pain medications they are taking, if they are taking any. So next we have inspection. This is where we want to look at the patient's posture as well as their spine. So we want to note if there is any kyphosis, lordosis, do they have any scoliosis deformities, do they have a shifted stance, are their shoulders protracted, are they symmetrical, do they have muscle asymmetry? We want them to perform the Adams test, which is basically them just bending over. We want to see what the spine looks like when they bend over. We want to know if there's any a fawn's beard or any skin markings. We also want to look at their gait. We can look at this when they first come in, or we can just ask them during their examination to walk for us. We want to see if there's any intelligent gait. Do they use, or do they need to use any assisted devices? So do they need a cane? Are they using a walker? As well as sit to stand. So we want to see how the patient gets up from a seat. Are they shifting their weight? Do they need to hold on to the chair to get up? Just looking at how they get up from a chair. So next we have palpation. When we're palpating, we want to palpate anteriorly and posteriorly. So on the anterior side, we want to palpate the ASIS, the pubic symphysis, the umbilicus, and the iliac crest, as well as for the posterior side, we want to palpate along the spine, the greater trochanter, ischial tuberosity, the iliac crest again, as well as the sacrum. And when we are palpating, we are looking for any tenderness, hypomobility, hypermobility, as well as a step-off deformity along that spine. So next is range of motion. We want to look at the range of motion for the back and the hip. So for the back, we're looking at flexion, extension, lateral flexion, and rotation, as well as for the hip, flexion, extension, internal rotation, external rotation, adduction, abduction. And so we're looking for if there is symmetry between both legs? Um, are they within the normal range of motion? Do they have any? Is it not within the normal range of motion? So next we have the selective tissue test. The first test we're going to talk about is the straight leg raise test. This is when the clinician is raising the leg on the involved side. They're going to raise it until pain is felt or until full range of motion is met. And this has a sensitivity of 66% and a specificity of 67%. The next test we're going to talk about is the cross straight leg raise test. This test is a variation of the first one, pretty much the same thing as the first one, except the clinician is on the uninvolved side. They're going to raise that leg to see if there is pain felt on the affected side. And this has a sensitivity of 29% and a specificity of 88%. The next test we're going to talk about is the slump test. This test has a sensitivity of 84% and a specificity of 74%. With this test, there is a series of steps. So first, the patient slumps forward. They keep their cervical spine neutral. They have their shoulders rounded. And then they're going to bring their chin to their chest, and the clinician is going to hold them there. And then they're going to extend their knee, and then they're going to dorsiflex their ankle. And they're going to do the same thing on the other side, and we're looking for pain. And if there is pain, we want to have the patient go back to a neutral spine to see if there's pain from muscle or if the pain is coming from the nerves. So there are other selective tissue tests. The first test is the tension sign test. This is looking at the sciatic nerve. The femoral nerve tension test is looking at the femoral nerve root compression, and the Milgram's test is looking at the pressure in the discs in the roots. The next thing we're going to do is look at the reflexes. We're looking at the patella reflex, medial hamstring, lateral hamstring, post tib, and Achilles. This is assessing L3 all the way through S2. And we are looking to see if there is any response at all, slight response, a normal response, a little bit more than normal, and then a super hyper reflexive response. The next thing we're going to do is look at the myotomes. We're looking at the strength of the patient. So we're just seeing through L2 through L1 through S2. L1 and L2 are hip flexion. L3 is knee extension. L4 is ankle dorsiflexion. L5 is great toe extension. S1 is ankle plantar flexion, eversion, and then hip extension. And then S2 is knee flexion. And we're looking to see can the patient hold that position? Do they have a little bit of weakness, or can they not hold it at all? Is it present, absent, or diminished? And then the last thing we're going to look at is dermatomes. So we're going to assess L1 through S2, which is anterior to posterior, making sure that we have the patient's consent, because some of these dermatomes are in areas that are a little bit more personal. And so we're just noting if there is any difference of feeling on each side. Does the patient feel it at all? Is it there but not as strong, or is it completely absent? I don't feel anything. And then lastly, we're going to do our assessment and our plan of care. So what are our findings from the evaluation? What did we notice within the patient? And can we make a diagnosis? And what is our diagnosis? And then we can also do diagnostic imaging, which consists of either a radiograph, a CT, or MRI, just depending on what the patient's socioeconomic status is and healthcare plan is, just to get a better look, because it is hard to know what is actually really going on inside the body, especially along the spine, without imaging. And then if that patient had any of the red flags that I mentioned earlier, so the unexplained weight loss, the bladder and bowel changes, or any night pain, we do want to refer that to the physician, or refer the patient to the physician, because that is something that needs to be looked at right away. And then so this is my template of how to conduct a low back examination.